So, Anne, recently on social media and in my world, as our audience knows, or some of you guys might not know who's listening right now, I work for a company called Somnomed. I work for the manufacturer.
Interesting. I'm actually looking at an article right now.
Are you? About what?
About a device by Somnomed, the Somnodent. And so there was recently a study that was done that was looking at the utilization of mandibular advancement devices, specifically the one from Somnomed, versus what the study title is CPAP, but it actually wasn't against CPAP, it was against APAP, which is a big difference, right? So I actually think that this is a fascinating study, but what have you been seeing?
Well, I was talking about, when you said that, I just assumed you were talking about the Journal of American College of Cardiology.
Yeah,
JACC.
exactly.
That's
exactly.
the same one?
Yeah, it's the same exact study.
Page, yeah. And so we've just been getting flooded, and the word non-inferior keeps getting thrown around on social media, and people are doing like these TikToks and imaging. And I said, man, I can't wait to get with Anne.
Yeah.
And I can't wait to kind of dissect this. I know that one of the things you're passionate about is data.
Yeah.
And in my industry, unfortunately, what Ann and I share is that when we go hear people speak or we watch people online, and there for a while, and not going to call anybody out on this, but everybody just gives their opinions.
Yeah.
And what I love about you and the podcast and even our friendship is that you always have data. Like you won't just say just to say, there's data behind it. And so I really want to get your input on this.
Yeah.
I mean, I think I trust you the most, not only as a friend, but in what we do and sleeping around the podcast. So would love to get your 2 cents on kind of a quick kind of breakdown on what this means and why are so many people celebrating non-inferior?
Sure. So I think one of the things that first and foremost should be celebrated outside of even talking about this is the fact that where we are in sleep medicine right now is transformative, right? We're seeing that the amount of different options that are becoming available for sleep disorders in general is only growing. So now we're seeing that we have your CPAPs, BiPAPs, AutoPAPs being available for sleep apnea. That's been available for decades now. We have hypoglossal nerve stimulators. We have mandibular advancement devices. We now are seeing medications, the Apnea medication, which is a combination of oxybutynin and atomoxetine. We're seeing that the Eli Lilly phase 2 data has just come out for its GLP-1 GIP agonist, which is going to be very interesting. That's data that we definitely need to dissect. But the question that has prevailed is that PAP has historically been the quote-unquote gold standard, and some will say like the preferred therapy. My favorite quote is from Atul Malhotra, where he was like, I remember I was called out and was like, whose preference, yours or the patient's? And the reality is you see this insecurity in sleep medicine to not do the right thing for the patient, right? We always are like, we made a pledge, we'll do no harm. And so everyone will say, I want the data, I want the data, I want the data. But then we generally make our own interpretations of the data. And I think one of the challenges is that when we're looking at information within a study, we first have to also acknowledge how was the study designed. And so this was a study that was a non-inferiority study design. What does that mean? It means that I cannot prove superiority. I cannot prove that mandibular advancement devices are better than CPAP. Why? Because the way the study was designed was based on the premise that CPAP has been studied and demonstrated that it can have a 1.3 to have about 5.5 millimeters of mercury reduction in blood pressure, on average about 3.3. When they designed the study, say, can we show that mandibular advancement device can go toe-to-toe at PAP in being able to reduce blood pressure? They said, well, the minimum was 1.3. We're going to just round up, and we're going to say that we want to power the study, meaning we need to recruit and have the numbers to analyze to demonstrate we can at least get a 1.5 reduction. So even if they saw above that reduction, it doesn't prove superiority. Okay? Because the design of the study cannot prove superiority. It can only prove that you're able to do just as well as the CPAP because of the fact that I use CPAP thresholds to be studied, right? And so a couple of things that I think, again, when looking at data is important to say, who is the population being studied and is this generalizable data? This is a study that was performed in China. And so the patient population enrolled were all Asian. My patient population, I have a very, very low percentage who are Asian. And the reason that that's important to make that distinction is because although we many times will think about weight as a driving factor, weight distribution and BMI characterization is different in Asian population than Caucasian or Black or Hispanic. And actually lower BMIs are considered obese because of their skeletal frame. The other part is that there are distinct differences in craniofacial features where perhaps a mandibular advancement device may actually be even of greater benefit than other individuals. Because in many Asian populations, you're going to have maxillary hypoplasia, you may have a smaller chin, you may have a more recessed chin, and so therefore being able to adjust those craniofacial features may make also a more significant difference than if I were to put that in a more diverse population. So that's the second piece. So let's unpack what the study actually showed. And so it's a very, very well-designed non-inferiority study, but it is really important to emphasize it's non-inferiority. When they looked at this, they enrolled 220 people, and they also stratified it to make sure that they had under and over 60 years of age. So again, not just looking at I'm greater than 50, and that's a very unique phenotype, but being able to say we have a larger distribution of ages, and then they analyzed that separately as well. They also looked at different things like BMI and glucose control, or are they pre-diabetic or diabetic. Now, things I want to make sure that I'm stating accurately, I think are also really important, because the big argument within PAP versus mandibular advancement devices also is they're going to do the same job and people are going to use them more, right? This study actually doesn't show that. So when we actually look at some of the data in regards to adherence, there was an embedded compliance microrecorder chip in the dental device. So we actually were able to get a measure of it. And so what were some of the things that they had found? So what I'm going to do is I'm going to get to that 6-month adherence. And so in the mandibular advancement device group, 89% of participants completed a 6-month follow-up. And of those, 86.7% had valid adherence data, okay? So not everyone had valid adherence data, and we'll compare that valid adherence data to the CPAP group, because the CPAP group, 97% had valid adherence data. So that's a big difference, right? Being able to monitor how adherent we are is also another big parameter that is gonna play into this. The second part is, what was the median duration of usage during the 6-month period, from first day to last day to 6 months? Mandibular advancement device, the median, so if I don't have an even distribution, the median and the mean are going to be different. The mean means that I'm right in the middle. Or if I were to average and kind of then divide it, that's right in the middle. The median is I'm going to put all the numbers out, I'm going to select the one in the middle, and that may not be the same as the mean. It was 5.5 hours per night. Okay? Only 72.9 used the device for 4 hours or more per night. And 56.5 used the device for more than 6 hours per night, right? So we're seeing that people still aren't utilizing it the whole night, which is a criticism of the CPAP as well. But how did it play up against the CPAP from that regard? So with that, we see that the median usage for CPAP was 5 hours.
Wow.
So 5.5 versus 5 hours. The second was that 69.4% using more than 4 hours a night, which is pretty good. It's more than 56. However, only 23% were using it more than 6 hours a night. So again, mandibular advancement device did perform better there, right? For greater than the 6 hours. Now, this is the other part that I think is important, is that how do we measure the success of obstructive sleep apnea treatment in general? Again, I don't agree with this measure, but this is what the standard is. It's AHI, the apnea hypopnea index. How many times an hour are we having breathing issues? For the mandibular advancement device, the AHI was 10.8. For the CPAP, 2. So 10.8 is still considered mild obstructive sleep apnea, and 2 is considered no longer have sleep apnea, less than 5, right? So those are just really important parameters to look at. Now, what it does demonstrate, however, is that when doing a 24-hour blood pressure, this means I put a blood pressure cuff on someone and I'm constantly cycling it so that I get it during wakeful hours and sleep, right? with that stated, why is that important? Because we know that people who, even if they don't have high blood pressure, we are supposed to go to a dipping status overnight. People who are at risk for high blood pressure, they will go into a non-dipping status. What does that mean? If my blood pressure during the day is normally 115/75, when I go to sleep, it will probably go down to like 105/70 or over 65.
Right. So
that's a
systolic,
dipping.
diastolic
Go down.
Okay.
It's a dipping, right? And that makes sense because I'm in a relaxed parasympathetic state. For people who are pre-hypertensive, so you go to a doctor's office, take your blood pressure, it looks normal.
Right.
We will see that during the night, they're in a non-dipping status. The same blood pressure you get during the day, you're getting at night. So even though it's not hypertensive, it's telling me, why are you not having this recovery period?
Right. The dip.
So we're seeing that both the wakefulness and the sleep parameters are improving. So what this study is telling us is that when comparing the mandibular advancement device versus, again, it wasn't CPAP, it was APAP, AutoPAP. What's the distinction? CPAP is when I give you a fixed pressure.
Constant.
To be able to treat you. AutoPAP is where I give you 5 to 15 maybe as the pressure, and that algorithm determines what pressure.
That's right.
We already know, besides mandibular advancement devices, APAP, CPAP studies have demonstrated CPAP is superior to APAP in blood pressure management, right? So we are comparing a APAP, calling it a CPAP against a mandibular advancement device. That part is a little bit of a lexicon mix-up.
Right.
And I do think that the study does demonstrate non-inferiority. So you're no worse off. It does not demonstrate you're better off. The other data is we're not seeing necessarily that we're blowing you out of the water in terms of how much we're using you, right? But we're seeing, despite me not using you a whole bunch more, and despite me not lowering your AHI a whole lot more, we're seeing you're still non-inferior into a very important parameter, which is your blood pressure. So I think that this is a good starting place for us to be able to then say, how do we replicate this, number one, across different populations, to see that this is held up when we are using different craniofacial features and other risk factors, but also really truly doing it against CPAP versus an AutoPAP, and being able to say, do those parameters make a difference? And then when I go beyond 6 months, what does that look like?
I appreciate it because I think that there was so much noise out there on both sides, right? And both different companies. So I always appreciate your input. And so thank you for clarifying that, not only for me, but for our audience. Thank you guys so much.
Did this episode leave you wanting more? Then make sure you subscribe and check out this episode right here.